Okay, you guys ready to go?
Yep, we're ready to go.
All right, perfect. Okay, why don't we kick it into gear? It looks like we have a good group assembled. So welcome everyone to the latest edition of National Journal Club. I'm super excited to have our colleagues from the Lehigh Valley program present today, and it's burn and toxicology. I think this is a fascinating topic that was not on my radar, so I'm excited to go through these articles. Just a reminder for rules of engagement. If you'd like to speak, raise your hand. We also have the chat function, so feel free to chime in the chat and we will be happy to take questions, comments, etc. So with that, let's get rolling. Again, those of you who are Twitter folks, we use the hashtag ACMTNJC, so feel free to get some chatter going there. And without further ado, let's go for it. I'd like to introduce Dr. Robert Cannon, who gets the Above and Beyond Award because he's between night shifts. So thank you so much for being here. Program Director and Fellows Alexandra Amaducci and Derek Fixie. So thanks so much for doing this. Let's go for it.
All right, very good. Thanks, Steve. You call it the Above and Beyond Award. I call it the Stupidity Award because I wasn't smart enough to request off, but thanks. I appreciate you giving us the opportunity to present at National Journal Club. I just want to get a little bit of background on kind of where we sort of came up with this topic. Of course, our institution happens to also be a regional burn center. And of course, the worlds of burn and toxicology do intersect occasionally, particularly with your house fire victims. And what we've noticed at our institution over the past couple of years is that our burn surgery colleagues seem to have been quite resistant to the idea of giving hydroxycobalamin empirically in cases where we otherwise thought it was indicated, those being significant mental status depression, hypotension, and lactates greater than 8. And so much so that they have occasionally even canceled the order and even removed the consult for the tox service. And their kind of thought was that hydroxycobalamin causes kidney injury and we shouldn't be using it, and it doesn't change mortality. And that's kind of their line in the sand. And so we felt we would sort of explore maybe some of the literature that exists in their world and maybe that we hadn't seen, and kind of get their perspective on it, come up with our own perspective on it, and at least help facilitate the discussion on risk-benefit ratio and how to go about this. And ultimately, we're hoping to generate some discussion with hopefully some other folks that may be on the webinar that happen to work at burn centers and be interested to know their particular experiences. We also figured we'd bring into the mix at least one modality that does exist in the burn resuscitation world, which may be a big confounder to the hydroxycobalamin and oxalate nephropathy issue. So that's kind of where this came from. So hopefully we'll generate some discussion. Without further ado, I'll give it up to our fantastic fellows, Drs. Amaducci and Fixie. Thanks.
Thanks, Dr. Cannon. Yeah, you did a great job covering kind of the background leading us to the point of this discussion. And we've had a number of patients that are found down that meet criteria for hydroxycobalamin. So to back it up a little bit more, since we were encountering resistance with our burn colleagues in giving hydroxycobalamin when they rolled into the ER, we went ahead and developed some pre-hospital protocols because we know that we needed to get the antidote on board earlier rather than later. So patients who were involved in a fire and met the criteria of having altered mental status and hypotension, from our standpoint, would meet the criteria of receiving hydroxycobalamin. We actually have a protocol in place with our EMS colleagues that they can give it. Once they hit the doors of the ER, the trauma bay, and we can draw labs, we later on will find out that they have a lactate greater than 8. And so the big question arises is, do we give hydroxycobalamin if they haven't gotten it, or should we have given hydroxycobalamin if they did get it? We as toxicologists say undoubtedly yes, and our burn colleagues say no. So instead of just, arguing, we decided to kind of dive into the literature a little bit. So Dr. Fixie is going to give us a little background.
Yes, we won't dive deeply into this article. It's just an introduction, just to bring up acute kidney injury in burn patients. And as Alex and Dr. Cannon mentioned, burn surgery seems to be hesitant to give hydroxycobalamin, mainly because of this potential for acute kidney injury, which Alex is going to dive into deeper in a second. And while we may not agree with them all the time on when to give hydroxycobalamin, we do agree that burn patients are at risk for AKI, as evidenced by this article here. And this was a rather large retrospective cohort study of just over 1,000 patients that recently came out of Parkland, which we all have heard about, down in Texas, titled Acute Kidney Injury After Burn, a Cohort Study from the Parkland ICU. Next slide. And like I said, we won't dive too deep into it, but the conclusions that they reached essentially are that ICU burn patients are at quite high risk for acute kidney injury, with about 60% of patients that are admitted to the burn ICU experiencing some degree of AKI. And as we might imagine, as their burn severity increases, they have an increased risk of AKI. And mortality of all the patients who developed acute kidney injury was about 20% or so, which is much more than the amount of patients that did not develop acute kidney injury. Only about 3 to 4% of those patients ended up dying. And as we might imagine, acute kidney injury was associated with mortality in all of the groups, all the burn groups based on total body surface area, except for the patients with the most body surface area burned. So patients that were more than 40% burned actually did not have a correlation with mortality and AKI, which makes sense if we think about it, because those patients are probably unfortunately dying from other causes like sepsis and infection and other issues.
Cool. Thanks, Derek. So the first article that we're going to go over is a letter to the editor. And it was entitled Risk of Oxalate Nephropathy with the Use of Cyanide Antidote Hydroxycobalamin in Critically Ill Burn Patients. So like I mentioned, it was a letter to the editor, and couple of important points about this letter, is that it came out of the burn unit in France, and it was also part of the Prono Burn study group. So I think that shines a little bit of bias on it when we talk about what they discovered. So this letter talks about 2 case reports of critically ill burn patients. And so the first case is a 56-year-old male who sustained 16% burn. This patient was intubated on scene and received 5 grams of hydroxycobalamin. And then 7 days later required renal replacement therapy. They decided to go ahead and do a kidney biopsy, which showed some mild acute tubular necrosis. And then they also noticed that there were some calcium oxalate crystals in the lumen of these renal tubules. They did some genetic testing, determined that this wasn't due to a genetic cause. And then they also described a second case. This was a 40-year-old male. He also sustained smoke inhalation and had 30% total body surface area of burns. Similar to the first patient, had required renal replacement therapy on day 7. And they noticed that he also had similar kidney biopsy findings. And this was the picture that they included in this article, showing that this was a control group down here on the left in terms of assessing for urine oxalate crystals, and this was the treated group. The middle picture shows the renal biopsy showing some ATN and then these tubular deposits of calcium oxalate crystals, and they're actually referring to this area here above the black arrow. And then the third picture is calcium oxalate crystals under birefringent or polarized light. So what they did is they measured urine oxalate crystals in 15 consecutive patients. 6 of these patients had received hydroxycobalamin, but the other thing that they mentioned is that the patients that had higher burn surface area also had higher urine oxalate compared to no treatment. And so the conclusions that they drew were that patients treated with hydroxycobalamin had a AKI odds ratio of 5.8 and a renal replacement therapy odds ratio of 4.3. So those are pretty high odds ratios. And their final sentence was that hydroxycobalamin administration appears to be associated with calcium oxalate nephropathy, and that in turn leads to AKI. So a few limitations to this letter. This, like I said, this wasn't a study. This wasn't the editor. Again, these are Byrne authors, and this is association, not necessarily. I'll stop here for a minute and see if anyone has any comments or questions or just kind of thoughts on everything so far.
Really interesting. I'm just wondering if you guys have, was there any, there's just some noise interference. I'm not sure if there was rustling or something.
Okay, sorry, that might have been our paper as well.
Oh, okay. Okay, great. Yeah, fabulous, really interesting paper. And again, if there are questions, please drop them. What I find so fascinating is that I think the strongest advocates of use of this antidote have been from France. Mm-hmm. And a lot of those older studies have, basically just advocated using it for all burn patient or smoke inhalation patients, particularly those in the, in the field. So now this is the burn category, but it is quite fascinating about these observations. Any comments from the group? Okay. All right. Well, why don't we press on? I don't see anything right now.
So the next article that we're going to talk about, so the first article says that hydroxycobalamin causes oxalate nephropathy. The second article touts that hydroxycobalamin causes AKI. And so this article is entitled Association Between Hydroxycobalamin Administration and Acute Kidney Injury After Smoke Inhalation. And this was a multi-center retrospective study. Now, again, this is out of France, so we can talk about external validity in terms of, do patients in France have the same smoke inhalation injuries, same treatment modalities as we do here in the United States. And then also the last author here, Matthew Legrand, was the same author as the prior patient. So this was a multi-center retrospective study looking at 21 ICU in France. And I think it was over a 6-year period from 2011 to 2017. And the primary endpoint that they were looking at is the risk of acute kidney injury. And their bottom line was that there was an odds ratio for acute kidney injury of 1.597, and then for severe acute kidney injury of 1.772. And they also reported that hydroxycobalamin was not associated with survival after smoke inhalation. So their argument is if we have a patient with a smoke inhalation burn patient, if you give hydroxycobalamin, it's not going to influence their morbidity or mortality, and it's going to cause AKI. So what they looked at, they had screened 854 patients with smoke inhalation. They included 739 of these. About half, 386, received hydroxycobalamin, which is a pretty large number. I mean, I can certainly say at our institution that we've not given hydroxycobalamin 386 times in the past 6 years. And what they noticed that of these patients, 288 developed AKI and 186 developed severe AKI. And so we went ahead and looked into the definition of AKI, and they use the KDIGO criteria, so the Kidney Disease Improving Global Outcomes. And so they define AKI as any of the following. So increasing your serum creatinine by 0.3 milligrams per deciliter or more within 48 hours, or an increase of your creatinine to 1.5 times the baseline within the last 7 days, or if you have decreased urine output less than 0.5 cc's per kilo per hour for 6 hours. And then they also go ahead and break down and they stage the AKI as well. So stage 1 is 1.5 to 1.9 times the baseline, or 0.3 milligram per deciliter increase. Stage 2 is 2 to 2.9 times the baseline. And stage 3 is 3 times the baseline, or if you have a creatinine greater than 4. And they also have broken down the degree of urine output as well. So a couple different limitations in this study. Again, anytime you have a retrospective study, that can cause some limitations. They went ahead and excluded the patients that were discharged home alive within 24 hours, which I think excludes, and we don't know if they had received hydroxycobalamin or not, but we're excluding less ill patients. So you're including patients that are already more critically ill at baseline. And the mortality in the ICU was 39.2%, which is pretty high. But the patients that had hydroxycobalamin had higher severity scores and a higher mortality rate. And then there were certainly a lot of confounders as well. So in table 1, they talk about the different characteristics. And we note that the patients that received hydroxycobalamin, 42 of the patients that received hydroxycobalamin went into cardiac arrest pre-hospital compared to 4 patients that didn't. These patients had other comorbidities such as chronic kidney disease, diabetes, hypertension. They required vasopressors. So these patients were much sicker at baseline. And there was a significant difference in the number of patients of these that received hydroxycobalamin versus not. And then also, patients received nephrotoxic meds in the ICU too. They received aminoglycosides, they received glycopeptides like vancomycin, they received contrast for their CT, which we know doesn't necessarily cause AKI, but there are a lot of people out there that still believe that it does. And these patients were prone to developing rhabdo, which is also another confounder for AKI. So again, with this study, I think, the odds ratio for what they define as AKI was 1.597. For severe AKI is 1.772. But is this AKI clinically significant, right? So if you have a creatinine that goes from 0.4 to 0.7, they're saying that meets the definition of AKI, but is that clinically significant? Do these patients go on to develop, chronic kidney disease? And then also for the adjusted odds ratio were above 2 for if they have severe burns, if they received aminoglycosides, if they have chronic hypertension, and whether or not they had a pre-hospital cardiac arrest. So I'll pause here again for some discussion points.
Great. And again, please either raise hand or, drop some comments into the chat. I think this is a fascinating paper. What really jumped out to me was the issue of this is a retrospective view of, from, really impressive number, but just really smelled a lot of selection bias. Like how do they choose who got the antidote? And I'm not really sure that this can convince me one way or the other that we really, that we know. I can imagine, clinicians at the bedside throwing the kitchen sink at patients, so your sicker patient get the antidote. Yeah, so I think that's a definite confounder. And then, yeah, here we go. Here are some comments. So if you could see from Chris Watson in Boston Children, they had a young child declared brain dead after a house fire was complicated by cyanide toxicity. They got hydroxycobalamin. We were consulted the question of whether the patient could be an organ donor. We found these interesting reports of successful DRRT from cyanide toxic donors who'd been treated with the antidote, of which one had oxalate crystal deposition at the time of transplant. Subsequently resolved by week 6 post-transplant. We ultimately recommended a second dose of hydroxycobalamin to fully clear the patient's residual cyanide level and did not identify other tox contraindications. Not sure if anyone else encountered that. That's really interesting. I know that our colleague here in Chicago, Jerry Lakin, has published on who it's safe to transplant after brain death. I'd be interested to know if others have seen that. And then
that's an interesting article. I actually came across that article recently when I was looking at some of this stuff. I would encourage people to check it out. They actually had pictures of the kidney that they transplanted and how it was discolored. And on follow-up, the patient actually did really well. It was really cool case report. I'll just make one other quick comment that I noted here, which I saw that there's been another comment on that. And this was my thought exactly when I read this study, that when they looked at major adverse kidney events in this particular group, which they defined as death or renal replacement therapy and or persistent AKA at ICU discharge, there actually did not seem to be a correlation with those who got hydroxycobalamin in the development or the occurrence of major adverse kidney events, which really is probably the more clinically significant. So it would be interesting to know, I think, long term, what happens. Is it possible there's just a small bump in creatinine that's temporary, and in 2 weeks you're back to normal and it's no big deal? Those are questions that I think would be interesting to know.
Right, and I see a couple of questions here. I guess this is question back to Chris. If the treatment, the hydroxycobalamin was the donor transplant, if you could answer that in the chat. Yeah, and then also for you folks, do you think there's a plausible mechanism for hydroxycobalamin causing this? I know we'll talk about it with the oxalate. I mean, do you think it's the same thing, or what do you guys think?
Yeah, I mean, there's one line in the first letter to the editor that says that oxalate is an end product of the metabolism. And so, but I don't know specifically if there have been any animal studies showing that hydroxycobalamin causes the oxalate.
Yeah, when I I had the same question: is there a biologic plausibility to explain how this would even occur? I couldn't really find anything. The only thing that I could come up with is that vitamin B12 is a cofactor for methylmalonyl-CoA mutase, which is necessary to take methylmalonyl-CoA to succinyl-CoA, and then succinyl-CoA is necessary in the metabolism of oxalate by forming succinate and oxalo-CoA. I would think that if you increase succinyl-CoA formation, you should actually enhance oxalate clearance rather than inhibit it. So it seemed counterintuitive. Perhaps something in that pathway results in the precipitation of oxalate out if you enhance it. I don't know, but I couldn't really find anything other than that.
Great. I see a hand from our friends in Phoenix. Phoenix, can you go ahead?
Hey, my name is Jorge Castaneda from the Phoenix Banner University. I think that was a very interesting the studies there. I think that we don't have any doubt that burn patients had increased risk of AKI for numerous reasons. Probably the most common cause of this is acute tubular injury. On top of that, there are a couple of studies there that you mentioned that you can have like oxalate crystals that also may contribute a little bit to the kidney damage. So here is the point. One of the principles whenever we have a patient with AKI or at risk of AKI is to try to minimize any kind of like a nephrotoxic, either medications or either any kind of maybe antibiotics or any other kind of medications on other factors. So using hydroxycobalamin for all patients may not be like a kind of like a great idea, but maybe classify some patients may be a better strategy. And then if it's used, what probably gonna be is on top of following like a kidney function by checking like a serial urine sediment to see if you have increase in the oxalate crystals, because you can do this every day. You can check the sediment every day. And if you don't have any kind of like a increased crystals there, you may be okay. The patient may be worsening kidney function because other factors, but may not be due to the hydroxycobalamin. But thank you for sharing your topic.
Thank you.
Okay, great. Thanks for the comment. I'd like to bring it back to, I guess, the scenario that you painted up front. I kind of view it, you've got a, smoke inhalation victim or burn victim that's got, or like make it cleaner, smoke inhalation victim who's hypotensive, high lactate, low pH. Are folks not using hydroxycobalamin in that case? I'd be curious to know. So I see Andrew Coons is written in, hypotensive altered mental status, elevated lactate. And yeah, basically, I think that's the way most of us look at it. And I was curious if there are others that see this differently, because, what I love about, the topic is, when we get resistance from our burn colleagues, what are we seeing that's different? I think to the toxicologists, as Andrew stated here, I think most of us probably would pull it out in those cases.
Agree.
So that is quite
And,
interesting.
we can fix AKI. We can't fix a patient that's deceased from cyanide toxicity.
Right. We want not dead. Not dead is what we're
Exactly.
looking for. Yeah.
Not dead's better than dead. All right, we'll keep trekking on.
All right. Excellent.
All righty. So thanks for the comments, all. I'm going to take over at this point. And I know Alex nicely brought us through hydroxycobalamin, and I'm going to switch gears a little bit and talk about a therapy that burn surgery uses. I just wanted to have a couple of slides introducing it, because I know some of us may not be as familiar with it since we're not burn surgeons. But they can use vitamin C. And this article that's here is actually the landmark article in the burn literature that I found that kind of touts the efficacy of high-dose vitamin C as an adjunct to severe burn patients. This actually came out of Japan by Tanaka et al. And there's been a lot of kind of spin-off studies and smaller studies since then that all kind of say similar things. But essentially, they found in this article that by giving what they deem high-dose vitamin C, which the most common is 66 mg per kg per hour, so a pretty significant amount, you can significantly reduce the amount of fluid resuscitation that is needed. And therefore, they postulate that because of this decreased fluid requirement, it showed lower ICU lengths of stay, lower rates of intubation, and a lot of lower rates of other adverse downstream effects. And they also postulate that vitamin C is an antioxidant and a free radical scavenger, and so that will help with a lot of the potential burn as well. Next one. And it's really begun to, from what we can see, make its way into a lot of burn protocols. I know we talked a little bit about at the beginning about burn at their institution, who's using it and who's not. Our burn surgeons are using it. This was just an example of a protocol that's out of Texas as well, of on the burn service, where they recommend high-dose vitamin C infusions to burn patients in the ICU. Next slide. And so really, this is going to be the third article here. I wanted to talk about, but does vitamin C, this treatment that burn surgery is more willing to give, at least in our institution, than hydroxycobalamin, can vitamin C cause acute kidney injury as well? And this was an article out of 2016 in the Journal for Burn Care and Research, entitled Oxalate Nephropathy After Continuous Infusion of High-Dose Vitamin C as an Adjunct to Burn Resus. All right. And it was really a case series. Presented two patients. The first one was a 31-year-old female, and the second patient was a 20-year-old male. And they both had very significant burns, upwards of 65% total body surface area burns. And I'll leave this one up as I talk through it, just so you guys have some time to look at this chart. It's a little bit wordy, sorry. But essentially, patient one had burns sustained from residential fire, and she initially received lactated ringers for resuscitation that was titrated to an endpoint of urine output and tissue perfusion. And you can see in the first column there, the amount of fluid she kind of got over time. And unfortunately, even despite this fluid resus, she did have worsening hypotension requiring vasopressor support. She ended up requiring escharotomies of her right upper extremity and her bilateral lower extremities, which they thought was partially due to the burn, but partially due to the amount of fluid she was getting. And then they decided to start a high-dose vitamin C infusion at that 66 mg per kg per hour at hour 11, as you can see in the chart there. And she ended up receiving a total of 101 grams of vitamin C over 18 hours, so pretty high dose there. And what they saw is that temporally associated with the initiation of vitamin C, she developed an AKI. So you can kind of see on the creatinine what she came in at. She was hovering around 0.8, 0.9, and then with the initiation of vitamin C, she bumped up to 1.4. And so they postulate that since it's temporally related to vitamin C, it may have started to cause the AKI. The second patient, similar story. Unfortunately, he was a burn from a steel plant, and he as well got aggressive fluid resuscitation. He required a lot more fluids than the first patient, but they were doing it weight-based. I think he got something like 30 liters over the first 24 hours. Yeah. He also developed hypotension requiring vasopressors, and he coincidentally required the exact same escharotomies, the bilateral lower extremity and right upper extremity. And he had vitamin C infusion started as well. This was started a little bit earlier at hour 8. And he ultimately received a lot more, 224 grams, but that was weight-based dosing. And he, unlike the first patient, started with what we presume is a baseline AKI. They don't mention they don't mention that they have a baseline kidney function on him, but it seemed to worsen after vitamin C was started. And next slide, please. And unfortunately, both of these patients did end up dying. Patient 1 developed a pretty severe metabolic acidosis with lactemia and worsening AKI, although they don't mention the exact numbers of her creatinine or GFR. They were planning to initiate renal replacement therapy, but she died before it could start. And then for our purposes, the kind of interesting fact is that on biopsy, or on autopsy rather, her both kidneys did show calcium oxalate crystals and deposit in there. And patient 2, once again, similar. He had a slightly more prolonged course. He died on hospital day 3. He actually was able to be placed on hemodialysis and continued to worsen despite that. He ended up undergoing a left AKA. He ended up opening up his belly to look for necrotic bowel and everything, which they never found. And he was pronounced brain dead at the hospital day 3. And they did an autopsy, which also showed this calcium oxalate crystals. And the authors have a couple conclusions and really limitations to this. Obviously, it's a small study, just really 2 patients in it. And really the kind of crux of it is causation versus correlation, right? So both of these patients did have acute kidney injury, but they also had very significant kind of burns at upwards of 65% total body surface area burns. So as that kind of first introductory article looked at, they were already at risk of having AKI. So it's hard to say whether the vitamin C and subsequent calcium oxalate crystal nephropathy was the cause of the AKI or just a kind of a red herring, or they kind of both work together to cause this kidney injury. I will say that the authors mentioned that burns itself typically should cause ATN if it's a cause of AKI and should not cause calcium oxalate deposition. And so they go on to conclude that despite the fact that vitamin C can cause this calcium oxalate crystal nephropathy, the benefits of high dose vitamin C may be greater than the risks, and kind of more studies are needed. And we're going to look at shortly another case and how vitamin C is postulated to cause calcium oxalate nephropathy. But I will, for now, stop for any questions or comments.
Okay, folks, again, if you'd like to chime in, raise your hand or drop something into the chat. Yeah, fascinating paper. You look at these cases, these data, and you just wonder, is there a sweet spot where the vitamin C has a beneficial effect? And then, is there also a point where it's just outweighed by the amount of renal injury you're going to get from the burn, rhabdo, et cetera, altogether? Very unclear. So I'm not seeing any comments from the group. Not seeing any. Why don't we push on to the next article?
All right, so this article is ascorbic acid. This will be the last article. Ascorbic acid induced oxalate nephropathy, a case report and discussion of pathologic mechanisms. And the reason we chose this is not as much for the case, although we'll go through that briefly, but more for the pathologic mechanisms, because there were quite a few cases that we found and papers that we found written describing vitamin C induced oxalate nephropathy, but a lot of them didn't have discuss the mechanism by which it occurs. So I thought this was interesting. And this was actually out of Baylor. It's another Texas article. It was in CEN case reports. And the case presentation that they start with at the beginning is a 69-year-old male with a past medical history, really significant for BPH, as well as a small bowel resection. And I distilled it down to kind of the important parts here, but presented hemodynamically stable. They mentioned that he was lethargic but arousable, and he was confused with word finding difficulties. And is on initial kind of ED lab workup, he was noted to have a pretty significant acute renal failure, or AKI, with a creatinine of 9.51 and a BUN of 135. And during his admission, he underwent obviously multiple testing. They looked at autoimmune causes of this. They looked at all his P-ANCA, C-ANCA, all that kind of stuff. And underwent urine testing, which just showed some red blood cells, much greater than white blood cells. He underwent a renal ultrasound, which ended up being negative. And then ultimately on hospital day 5, due to no improvement in his kidney function, he was started on hemodialysis. He underwent 4 sessions with improvement. And he ultimately ended up having a renal biopsy to look for the cause of this acute kidney injury. And they found interstitial edema, fibrosis, inflammation, and then what's interesting to us is this calcium oxalate crystal deposition and nephropathy. You can see there where the arrows are, they're pointing out the calcium oxalate deposition. And they kind of conclude this case by getting a better history really from the patient. And I find out that he's been taking 2 grams a day of vitamin C for 2 years. And just to put that into perspective, because I didn't know the kind of the daily requirement, but the dietary requirement of vitamin C is really 75 milligrams per day. And depending on what studies you look at, they mention anywhere from about 2 grams a day to 10 grams a day as being a potential for cause, although there are outlier case reports of people on as little as, I found one with 400 milligrams per day, or a single IV dose of 45 milligrams that was postulated to cause calcium oxalate deposition and nephropathy. But 2 grams is kind of on the lower end of reported toxicity from vitamin C. And what they recommended for the patient was to discontinue vitamin C, which he did, and they put him on a low oxalate diet. And they found that upon discharge, his renal function had improved. I think it was down to creatinine of 3 something, although they don't mention how long after admission that was. So the more pertinent fact was that at 4 months later, when he came back for a checkup, his creatinine improved to 1.75. And they did a lot of legwork for us. They had a kind of literature review at the end of this, where they pulled up, was it 12 or 13 cases of vitamin C induced calcium oxalate nephropathy. And as you can notice, and similar in our patient, is most of these had precipitating comorbidities. Our patient had the BPH and had the small bowel resection. And a lot of people had really significantly high creatinines, as you can see there. And some of them ended up getting better. Some of them ended up on permanent dialysis, and others ended up dying. So it's kind of a mixed bag, at least based on these reports. And so, and this is the really interesting part that kind of talk about how they believe vitamin C causes the oxalate nephropathy. And in the body, when you ingest vitamin C, essentially it gets oxidized to dehydroascorbic acid, and then it gets metabolized to diketoglutonic acid, and then is ultimately catabolized to oxalate, which can then be deposited in the kidneys, as we've looked at. And interestingly, they've kind of shown that based on the amount of vitamin C you're intaking, it's proportional to the amount of oxalate that's deposited. And it's this oxalate deposition that causes the kidney injury. And in our patient specifically, he had kind of 2 hits that are going to cause him to deposit or absorb more oxalate. He had this BPH, which caused post-renal obstruction. And whenever you have already hit your kidneys, they say that you're more prone to deposit more oxalate crystals, kind of worsening your kidney injury. And he also had the small bowel resection, which actually leads to increased oxalate absorption. So they mentioned that in normal people, kind of without a small bowel resection, without surgery on the bowel, typical oxalate absorption is about 20% or less from a diet. But if you have a small bowel resection, that actually increases to like 35 to 50% that you absorb. So you're actually able to absorb a lot more oxalate. We can go to the next slide. And they really conclude that vitamin C induced oxalate nephropathy can lead to acute kidney injury and sometimes requiring dialysis, as in our patient, but sometimes progressing to transplantation or even death based on those case series that they looked at. And they mentioned it's important to consider potential for vitamin C induced oxalate nephropathy, anytime you're giving excessive vitamin C supplementation, as we are in burn patients a lot, and they're getting, like those patients that we saw in the first case, 101 grams or 220 grams, so pretty high doses, especially in the setting of the comorbidities, like our patient had BPH and small bowel resection. And I will kind of stop there for any questions. And that was the last article, so we can use this as a kind of review of everything and wrap up, not just this case.
Great. I don't know if you guys can see in the chat, Fred Henredick has a question. Didn't see reference to ascorbic acid prescription in Legrand or Depret papers, unless I missed it. Has vitamin C become standard of care in burn units? Did they not control for that in Depret et al?
Yeah, that's a good question. And that's kind of why we brought this to the table. We know that vitamin C is recommended in the burn literature. We know that we do it here in our facility, but it's hard to know what they do in other facilities. But you're right, they did not control for vitamin C in the first two papers as well. So that certainly could have contributed, if not caused, the AKA and oxalate nephropathy in the first two papers as well, instead of the hydroxycobalamin.
Yeah, and I was wondering about that also. I'd be curious if folks would, either chime in verbally or in the chat. I know at Cook County, I spoke with our burn folks. They're very interested in fluid resuscitation, colloids, that sort of stuff, but they are not doing this. Just curious at other big trauma centers, what in burn centers, what, if this is something that we're running into. And also curious about, the initial question, the hydroxycobalamin, administration up front. It is interesting, the dynamic at our shop is it's generally administered by us or our trauma colleagues. But I do think that there's a little less enthusiasm like later. So, I'm sure each of us has a different dynamic at our hospital.
Yeah, for sure. And we're fortunate that our trauma colleagues are on board with us and agree that kind of like the benefit outweighs the risk. And that, if this is a potentially life-saving antidote, then we should go ahead and give it for these critically ill patients. And I think that's one of the points that we try and relay to our burn colleagues is we're not dispensing this like candy. We're not giving it to every single burn victim, smoke inhalation victim that comes in. This is for a selective group of very critically ill patients. And so, like we've mentioned, the literature, we don't feel supports that it either A, causes AKI or, even if it perhaps does, is it clinically significant? And if it's something that could potentially help the patient, there's really no downside.
Yeah. I guess, a question that comes up for us is in the pre-hospital setting, I've not been a big and enthusiastic supporter of just giving it to all smoke inhalation patients in the field. And, I guess this is a question mark in the backdrop. I mean, I'm not sure what to do with this. Is that further evidence that we shouldn't be giving it out willy-nilly per se? Or is it something we just need more study to know how to guide it? Really would like to see more controlled studies on who we're selecting and where do we really move the needle with hydroxycobalamin in general. And right, and it's, thanks to your comment, Brett, that's right. If no seizure activity pH is not too high, trial of fluid resuscitation may be a first step, right, with the all right, and then we also see hydroxycobalamin for pure cyanide ingestion seen in this group. What about in volunteer clinical trials? I don't recall that being reported. Looking at one now, don't see it in healthy people. I don't recall that either. I think that's right. Yeah, I mean, my impression is a combination. You've got all the issues with, with your burn patients, with reasons why it'll cause AKI plus this on top of it. So I do think we need to tease that out. All right, any final comments from anyone out there? All right, if not, any wrap ups from you guys?
I'll just say thanks for having us. Appreciate the discussion. And if anybody ever has any feedback or comments, or feel free to share, particularly your experiences at your own burn centers with your burn colleagues. We'd be happy to kind of know about that. So thank you.
Thank you very much.
Thanks.
Yeah, and I'll second that. Please keep this conversation going, and I hope it inspires maybe more study. But I think this was really a fabulous question, really well done. So really, to Rob and to you, Alex and Derek, thank you. This was a great conversation. Really appreciate it.
Thank you.
Thanks.
For everyone out there, our next National Journal Club will be March 9th. And it'll be presented by the Einstein group from Philly. So further announcements will come out later. But again, thank you to all the programs for your, stepping up and doing these and your participation. And we will see you next time.
Thank you.
Okay. Thanks, everybody.